You are so warmly welcome to this medal education session. We have got an amazing piece of education for you today with some experts waiting in the wings to have a lively discussion. But before we begin, it's really important that we share with you our disclosure information, and I'm just going to bring that up on screen just now. In today's session, we are going to be having a really lively discussion. We're going to focus it on three learning objectives. The first, to help us all to implement evidence-based strategies to monitor and manage progressive organ dysfunction in sickle cell disease patients. Secondly, to integrate emerging therapies and multimodal approaches into SCD treatment plans. And finally, to utilize patient-reported outcome measures and quality of life assessments to personalize sickle cell disease management. If you've joined us before on Medal, you'll know that we'd like to kick off our sessions by asking you some questions. So we would love to understand how you would manage some cases, and I'm going to share some polls with you on screen, and I'd love to hear your thoughts before we hand over to our expert panel for this evening. And this really helps just to get us focused on why we're doing this education, which is all about patients at the end of the day. So the first case that I'd love to hear your thoughts on and how you would manage it is this. A 32-year-old woman with homozygous sickle cell disease presents at the clinic. She has a history of childhood stroke, and after years of chronic transfusions, was recently switched to hydroxyurea. She has very rare pain episodes and has not experienced recurrent stroke. But despite significant fetal hemoglobin induction, she has severe hemolysis anemia and new exertional dyspnea. She wants to prevent further organ deterioration. Which intervention would not be appropriate for this patient? A, B, C, D, or E? If you could share your thoughts in that poll, that would be super. And if you don't know the answers, don't worry. We're going to be discussing all of these things today. So hopefully, if you don't know now, hopefully by the end of today's session, you will. Okay, the second poll is this. A 48-year-old patient classified as severe sickle cell disease phenotype due to frequent vaso-occlusive crises, despite optimal pharmacological therapy, is matched. He has a matched sibling donor and is interested in discussing curative options. When counseling this patient, which of the following is the most accurate statement? A, B, C, or D? If you could share your thoughts in the poll, that would be super. If you're just joining us, we're doing some polls. If you've missed the first one, don't worry. You can scroll up in the chat box on the right-hand side and you can pop an answer in there. If you're joining on mobile, just click the little chat icon at the bottom and you'll be able to see all of the polls. And we'll give you a few seconds just to read those statements. Okay, super. Thanks, everyone. Okay, the third poll and case for today is this. A 32-year-old female with sickle cell disease on a stable dose of hydroxyurea reports a progressive decline in her ability to perform daily activities and engage in her hobbies over the last 9 months. You review her pre-visit patient-reported outcome measures, and her ASCME scores for pain are stable, and her PROMIS scores reveal a physical function T-score of 38 and a fatigue T-score of 65. According to the principles of integrating patient-reported outcomes for personalized care, what is the most appropriate action based on these specific findings? A, B, C, or D? There's quite a lot in that, so I'll just give you a little second just to read that and to pop an answer on that poll. And we're going to be discussing all of these topics today. This is really just to get you thinking as we dive in. All of this is about a patient at the end of the day. So we really love to hear your thoughts about how this applies to the patients that you see. Okay, thanks everyone. Some great answers. I really appreciate it. Okay, and then I just want to ask three very quick questions, and it's just to ask how confident you are in each of these topics at the moment. So on a scale of 1 to 5, how confident are you in implementing evidence-based strategies to monitor and manage progressive organ dysfunction in sickle cell disease patients? 1, not confident at all, right up to 5, very confident. If you could share your thoughts in that poll, that would be super. And I'm just going to do these rapid fire. Okay, second one is this. On a scale of 1 to 5, how confident are you in integrating emerging therapies and multimodal approaches into sickle cell disease treatment plans? 1, not confident at all, right up to 5, very confident. Super. Thanks, everybody. Okay, and the final poll, and then we're going to hand over to our expert panel waiting in the wings, is this. On a scale of 1 to 5, how confident are you in utilizing patient-reported outcome measures and quality of life assessments to personalize sickle cell disease management? 1, not confident at all, right up to 5, very confident. Okay. Super. Thanks, everybody. If you have just joined us, we've done some polls. Don't worry, they're still open. You can see them all on your screen on the right-hand side in the chat box, or click the little message icon on mobile. You can scroll up and answer them all. Don't worry, you haven't missed anything. Okay, thank you so much to all of you for answering those polls. Hopefully, if you're not confident now, hopefully by the end, you'll be a little bit more confident after this amazing piece of education. Okay, I am going to hand over to our expert panel today, who is chaired by Dr. Nirmish Shah, and the panel will introduce themselves as we go through, but we're really excited to have this session chaired by Dr. Nirmish Shah. So I'm going to hand over to Dr. Shah and colleagues.
Hello. Welcome to our expert roundtable today. It's entitled Transforming Sickle Cell Disease Care. This is a CME accredited program, and before we begin, it's important to share our disclosures with you. And we're going to bring those up here on the screen now just for your information. But for too long, sickle cell disease has been viewed primarily through a lens of acute, painful crises. And while managing these events remains the cornerstone of care, this perspective really overlooks the more insidious reality. And that is that today we understand that sickle cell disease is a chronic, progressive, and systemic condition. And it's defined by cumulative organ damage. Despite the advances that have allowed over 95% of children to survive into adulthood, the median life expectancy still really lags behind, more than 20 years compared to the general population. And so it's a stark reminder that the disease has a relentless toll. So today we're here to address this critical practice gaps that still contribute to this reality. And it can be difficult to recognize and manage long-term organ dysfunction. And as well, it's difficult to integrate therapies that could change the disease trajectory. So our discussion today with our wonderful panel here is structured around 3 core pillars that directly address these gaps. Now, first, it's imperative for proactive monitoring and management of progressive organ damage. Second, we'll discuss how to navigate the rapidly and thankfully evolving therapeutic landscape that we have for sickle cell disease. And that goes from established agents that we have to the curative intent therapies that are coming and have already started to come and be available. And finally, the third aspect that we'll talk about is the need to integrate the patient's voice into clinical decisions and through the systematic use of either patient-reported outcomes or mindful discussions about how the patient is doing from day to day. So my name is Dr. Nirmish Shah. I'll be chairing today's roundtable session. I'm the director of the Sickle Cell Transition Program at Duke University, taking our kids and hopefully getting them as successfully as we can to the adult world. And we're doing an amazing job and doing that, I think, across many programs now around the United States. But joining today, I'm really thankful to have amazing hematologists and a panel here. We have Dr. Enrico Novelli, who is the professor of medicine and division chief of classical hematology at the University of Pittsburgh. We have Dr. Biree Andemariam, professor of medicine and the American Red Cross endowed chair in transfusion medicine at the University of Connecticut School of Medicine. And finally, Dr. Donnell Ivy, who's the chief medical officer for the Sickle Cell Disease Association of America, also the education manager at the Sickle Cell Awareness Group of Ontario, as well as the registry and mentorship manager for GANS at the Global Awareness Network for Sickle Cell and Inherited Diseases. So there are those pillars that we're going to go through. Again, I have a wonderful panel that I really encourage to chime in, but I do have a couple questions that I thought would be a nice way to start and kind of going through each of those pillars we were just talking about. So I'm going to start with really a question about progressive organ dysfunction. And the first topic is really focused on cerebrovascular health. And so for cerebrovascular health, for an adult patient with sickle cell disease, we have them now aged out of TCD screening. So the question comes up, how do we practically assess the ongoing risk of stroke? You know, it's important, of course, in pediatrics, do this up until age 16, but now as an adult, we're trying to understand, do they have the risk of stroke? Do they have a silent stroke? I guess that would, I think, would be an important question. And I thought the panel, and maybe we could start with Dr. Andemariam, you know, how do you assess your adult patients? Is there a routine process you go through? But what are your thoughts in those type of situations?
Thank you, Dr. Shah. You know, I think this is one of the trickiest parts of being an adult-focused sickle cell disease specialist is that we know that chronic complications, including the development of stroke later in life, can be devastating, and it doesn't happen infrequently. Data is out there that supports that 50% or higher numbers of adults have silent cerebral infarcts. And the American Society of Hematology guidelines from several years ago actually suggests, not with a strong recommendation, but suggests that every adult have at least one screening MRI to look for the presence of a silent cerebral infarct. And I think I think it's great that we have the guideline. I don't know how many of us are implementing that soft suggestion from the American Society of Hematology. And I'll tell you why, from my perspective. I think if we find a silent cerebral infarct in adults, I think we don't know what to do. And we don't have the evidence to support that managing them in the long term, the way that we manage children with chronic transfusional therapy, is really going to work in terms of secondary stroke prevention. But I'd like to hear what Enrico does there in Pittsburgh.
Yeah, thank you, Dr. Andemariam. It's not an easy answer. Personally, I try to individualize the screening to the patients. As you know, sickle cell disease is such an umbrella term for many different subtypes of sickle cell disease, and there's so much phenotypic variability. I inherit patients from the pediatric program with a history of stroke or a history of high TCD velocity. I inherit patients who are on chronic exchange transfusion. And so those patients, obviously, I manage very carefully. I oftentimes continue exchange transfusions throughout their adult life, and I do frequent MRI monitoring also for the development of moya-moya, and because the risk of hemorrhagic stroke increases in young adult life. And so those patients, definitely I screen, even if I don't have them on exchange transfusion, I monitor them very closely. I may do MRIs more frequently than in other populations. For those without a history of stroke who have SS, I do think it's a great idea to obtain MRIs. Many of them report some history of headaches or a history of variable neurological symptoms, that they may have a mild cognitive dysfunction that you can detect at some point. And so I have a very low threshold to get an MRI, for instance, before starting medications such as Imitrex for headaches or other migraine preventive strategies. And then for those with SC disease, what I mostly focus on is on management of cardiovascular risk factor and traditional risk factor for conventional risk factors for stroke in any population. And over there, for that population, I may not necessarily do screening MRIs, but I do keep in mind that blood pressure management, weight management, cholesterol management are important as in other populations. So it's a complex answer. I think but I agree that we probably as as a group, we don't do enough MRIs in adults with sickle cell disease. We don't screen enough.
And if I just may add, and I would love to hear Biree and Enrico's answer to this. So I know Enrico brought up the neurocognitive effect and the ability. And so I don't know what they think about potentially adding in their neurocognitive assessments to see if individuals with sickle cell on past histories of stroke are having some neurocognitive decline. And there are strategies that exist for things like ADHD, for individuals with Alzheimer's. Hopefully it doesn't get that advanced, but can we employ some of those strategies to help individuals that are aging, that are getting older? I know myself, I have a history of silent infarcts. I can see those on MRI. I also have a history of an aneurysm that has been repaired. But I'm also starting to notice that, my executive functioning is starting to slip a little bit. And so what do we do also in adding neurocognitive assessments to the evaluation?
Yeah, absolutely important. One of my first thorough one was actually on neuroradiological correlates of cognitive dysfunction, sickle cell disease, because I realized, a lot of patients have a very subtle cognitive dysfunction. You won't detect it unless you test for it, and it emerges only when you give very complex instructions on how to take certain medications or how to reach multiple subspecialists, and you notice that there's a difficulty in grasping the distance, so the details. So it's really an executive dysfunction, and as you pointed out, and it's subtle, and you won't see it unless you do neurocognitive testing. And what to do about it? I think even if you don't have strategies to prevent the deterioration, you can, at least if you can target more interventions, case management, social work interventions to help those individuals with their disease management. So I agree with you that that's another thing that is often overlooked.
Yeah, I would just maybe add one last part that I think it goes both ways, that when you're talking to a patient and their family and the thought is, okay, yes, let's do a screening MRI, the cognitive evaluation may indicate that there was a sign that there was a silent infarct when you end up doing the scan, or it might go the other way, that they had a history of silent infarct and that's why you're doing the cognitive evaluation. So, I've had patients where we did them together, and in fact, that's what we found, that both were the situation. So I'm going to segue to another organ, which is basically the situation of pulmonary hypertension, which has also had an evolving discussion in regards to screening. So, we often screen for pulmonary hypertension in various different ways. We have 6-minute walk tests. We have, of course, the echocardiogram, and sometimes we'll even add PFTs to really just get a better understanding of the risk for pulmonary hypertension. And so the question to our panel today is, like, what is your clinical approach to a patient who has borderline findings? So let's give an example. A patient who has borderline TR jet velocity, but is really otherwise asymptomatic. And so, what are the triggers, or what are the symptoms or signs that make you more concerned, or maybe allow you to have maybe a more in-depth workup for a patient who, again, you're worried about pulmonary hypertension? Maybe again here, Enrico, you can start here.
Yeah, so I think first we need to define borderline, right? Because for us in the sickle cell community, a tricuspid regurgitant jet velocity of 2.5 meters per second is already is worrisome. Although in most other diseases and in the general population, it will be reported as borderline by transthoracic. When you look at the transthoracic echocardiogram report. But for us, it's already a warning sign. Does that necessarily mean that the patient has pulmonary hypertension? That is right or cath proven? No, of course. But that is a biomarker of increased mortality risk. And so we do take it seriously. And as you know, there's been some controversy, at least in the past years. Some groups advocated for much more aggressive screening, and that was reflected in the American Thoracic Society guidelines, whereas others recommended screening for only symptomatic individuals. Now, who is not symptomatic in sickle cell disease with symptoms that may resemble those of pulmonary hypertension? So it becomes a moot point. At the end of the day, if you have hemoglobin SS disease, you've got to take this very seriously. I'd say the first thing I would do is to identify any pulmonary conditions that might be easily addressable, asthma, obstructive sleep apnea, in general, airway hyperreactivity. And so sometimes managing these conditions can lead to an amelioration of the jet velocity and pulmonary hypertension risk. And of course, the caveat, something to keep in mind, is that pressures will change in steady, when patients are in crisis, they will go up. This was published by Greg Cato and others, they'll go up acutely and then they'll go down. So very important to do the transthoracic echocardiogram when the patient is in steady state, not in an acute crisis event.
Yeah, I'll chime in here. I 100% agree with you. I think we oftentimes see echocardiograms ordered during a hospitalization, and the TR jet is higher than it would be at baseline. So it's important for everybody out there listening to this to really understand that checking an echocardiogram during the acute illness, especially if that's in the setting of a vaso-occlusive crisis, really should be repeated before you decide on next steps or classify them as having pulmonary hypertension based solely on a TR jet. I think for me, one of the most important things that I've done in practice is to develop a strong relationship with pulmonary medicine and to be able to discuss some of these cases with someone who's expert in pulmonary hypertension. I think as sickle cell experts, since we take care of a disease that has widespread organ involvement, sometimes we feel that we have to be the expert in everything. But I think engaging pulmonary experts and other subspecialists for some of the chronic complications that our patients experience is really important. And I think they're the ones that really stay on top of the guidelines within their own societies, which, as Enrico said, sometimes is in direct conflict with those that are developed amongst us hematologists. I've been practicing long enough to remember the days when we did start doing annual screening echoes in our patients. So for my adult patients, most of them still get an annual screening echocardiogram, but I have started to evolve in that thinking and really focus more on patients who are having cardiovascular respiratory symptoms, really, and following the American Society of Hematology guidelines that suggest in those patients who have respiratory symptoms, whether it's hypoxia or shortness of breath at rest or with dyspnea on exertion, to get a screening echocardiogram. And if the TR jet is above 2.5 meters per second, but maybe less than 3 meters per second, instead of reflexively sending them for a right heart catheterization, actually doing a 6-minute walk test and an NT-proBNP. And if either of those are abnormal, then referring for right heart catheterization. So there are some algorithms out there. I will tell you that you will miss some people utilizing that algorithm who actually do have right heart catheterization, proven pulmonary hypertension. So it's a mixed bag. We need more research.
Yeah, it's a good point, and I think that your point about involving and having a great collaborative opportunity with the pulmonologist is really important. I think we've had a great experience working with our pulmonologist and getting our patients seen pretty quickly, but also talking things out. So I think that brings up another situation that often comes up as well. I think we know with renal complications, the guidelines are, of course, to screen early, annually, look at for microalbuminuria. I think the interesting part here is that I'm seeing more with many of my colleagues as well, not only just a good collaborative effort with the nephrologist, but even just in fact prescribing ACE inhibitors and ARBs by the sickle cell docs. And this was brought up earlier as well. Like we're trying to do as much as we can, but how much is what we feel comfortable with, and do we have that collaborative opportunity with nephrologists? So I was just curious to see what your experience has been when you have a patient who has microalbuminuria or profound albuminuria. Do you reflexively just go ahead and start a medication? Do you then first refer? What is your sequence for that situation?
Well, I'll jump in just quickly. I mean, I really do prefer to refer to nephrology. But if you're in a setting where you don't have that easily at your disposal, I don't think there's anything wrong with starting an ACE inhibitor or an ARB, as long as you follow the blood pressure and the potassium and all the things that we're supposed to know as internists as well. So, what do you think, Enrico?
Well, so again, my answer may be a little more nuanced because I have some patients who don't want to be referred to multiple subspecialists. They're not ready to go to a nephrologist. I mean, those with advanced kidney disease, yes, sure, I can convince them, but others will say, oh, yet another person to see. So in those patients, I may just start a good old ACE inhibitor or ARB myself. I do usually want a 24-hour urine, not just a spot microalbumin level. And I obviously, I try to monitor the potassium too. That's an important thing to do. But I guess, I think the important message here is that kidney disease, like pulmonary hypertension, like neurocognitive dysfunction, is an insidious complication, right? It is, if you just follow the creatinine, you will miss this because there's glomerular hyperfiltration that keeps the creatinine low, even if there may be significant albuminuria or proteinuria. So very important to screen for this. Definitely, this one I very, very aggressively screen in everybody. And even a mild relative elevation of blood pressure that, again, may not meet criteria in the general population should be taken very seriously. And if I do see that there's a consistently high blood pressure, I tend to just place the patients on ACE inhibitors myself. I mean, they're relatively safe medications, and sometimes we want to reduce the burden of subspecialist referrals.
Yeah, if I could add to that, I 100% agree with you. I think that it's also an opportunity if you start seeing signals of the development of sickle nephropathy to discuss avoidance of nephrotoxic drugs, including the use of ibuprofen. A lot of our patients are using more ibuprofen than I think we really realize. And I think the other advantage of having them engage with nephrology early is, I mean, we see patients progress to end-stage renal disease, and it becomes incredibly more and more difficult to get patients like this on kidney transplant lists, especially if they have other comorbidities. So I think the earlier they're engaged with the nephrologist, and the earlier I think we can intervene on their behalf before end-stage renal disease, as they're heading in that direction, to get them with kidney transplant surgeons and programs and get them on kidney transplant lists for cadaveric kidneys if they don't have, a direct donor is really important.
I mean, I think all of this brings up, I think, an important point, which is, again, thinking about this from exactly what Enrico brought up from the patient perspective, like what's the burden that the patient has to go through to try and coordinate this care. So Donnell, provide your thoughts to, what truly is a good coordinated experience across different subspecialties, and maybe what also is the biggest gap right now in trying to make that happen. I mean, what are maybe ways to help make that happen, but what are the issues that we have right now?
Yeah, and I'll talk about it on multiple levels because I am fortunate that I've been able to do well in life. There are other individuals with sickle cell disease that unfortunately haven't been able to do as well as I have. And so it will be different depending on who the patient is. But as it was mentioned earlier, so I'm now 54 years old. So I'm getting older, and there are other complications I have to worry about as well. So I do have quite a few subspecialists that I see. I see a nephropatist. I see a someone for past aneurysms. To your point, I think it can become a large burden to sickle cell individuals with sickle cell disease to see many subspecialists. So I think good coordination would be a situation where maybe you're setting some of the special subspecialists they will have to see up on the same days. Maybe you're doing other things so that, as it was mentioned by Enrico, you might have the hematologist collecting some of the samples that the subspecialists need, and then they're doing a consult, without the patient there. There might be several strategies, but I think, now, particularly in this age that we have, some of the tools we have in terms of everyone has a phone, reaching out, making sure that they're aware that, hey, your appointment is coming up, making sure it's on their calendar. So that's the way I actually keep up to what's going on, because I have to check my calendar every day for work. I can then see that, oh, I have a doctor's appointment coming up as well. I think one of the most important things is that we also develop systems to follow up for patients that are missing appointments. As it was mentioned earlier, particularly as individuals age, or if they have neurocognitive deficits due to past history of stroke or maybe some other consequence, they may not be able to adequately coordinate their care. They may not be able to pull it all together and make sure they're making appointments. And we don't want those individuals to then fall out of the system and then no one follows up with them. So I would say if there are practices that have social workers, have community health workers that can identify, hey, these individuals are starting to miss more appointments, maybe we need to take additional steps to get them back into care. Maybe we need to find them. And in some cases, patients don't have that family support that others may have. So recognizing that as well, I would say a good system uses tools like the internet and phone, making sure, but then also if patients start missing more appointments, to take that initiation to, hey, use community health workers, let's go find this person. Let's go make sure they're getting back into care. I know that is an extra burden on the healthcare system, but I think we have strategies like the use of community health workers, like social workers, that can help us with that.
Yeah, and I'll kind of just wrap up that thought, because I think that's really, really important to recognize that. And I see this as we move our kids to the adult world. It's a huge different world when they move from peds, where we're really just surrounding them with a lot of reminders, and their mom and dad is on top of them, and of course, as you're saying, either the social work and the clinic. But then they get to the adult world, and we let them go a little bit, right? We're trying to foster independence, but to, again, what you're bringing up, we do need to recognize that as patients get older, as there's more complex appointments that they have to deal with, what are strategies? And I absolutely use exactly what you said. We use the MyChart messaging. I had clinic yesterday. I asked every single patient, do you have the MyChart app? Do you have that app on your phone? So it pops up, and we can send a message, text to remind them about appointments, but also if there are things going on.
And
So I'm gonna.
it will take that extra step that if a patient is falling out of care, we have to figure out strategies that make sure we identify them, because they're probably falling out of your care in the clinic and into care in the emergency room. And that's what we want to avoid.
Exactly. That's exactly a great point. So I'm going to move on. Again, just be a little mindful that we have great discussion points today, and what I want to move on to now is actually just about the treatments that we have. And I think all of us here are recognizing that we've made great steps in the right direction. We've technically taken some steps back here and there along the way with some of our development efforts. But let's talk about the approved therapies first. Let's just talk about what is here now for our patients. And before we kind of get into gene therapy and kind of the newest thought process, I just want to think about hydroxyurea, L-glutamine, crizanlizumab. How do you select the right therapy for the right patient at this point? How do you have that discussion? How do you consider which might be the right one for your patient? And so maybe here we'll start with Biree. We'll have you kick this off.
Sure. I think with respect to hydroxyurea, I think practice has evolved. I think if you asked me 20 years ago, my response would be, well, I'd follow the eligibility criteria for the multi-center study on hydroxyurea, which only enrolled adults 18 years of age or older, only individuals with SS or S beta 0 thalassemia, and only individuals who had, I believe, at least 2 acute pain crises requiring hospitalization or emergency department visit in the preceding year. And early in my career, if you were outside of those criteria, for example, if you had SC disease, if you were younger than age 18, or you had 0 or only 1 pain crisis per year, then I really didn't offer hydroxyurea. It was almost as if you were supposed to wait until something bad was brewing. And I think that our understanding with further research has really broadened, I think, how liberally we are giving hydroxyurea or recommending and prescribing hydroxyurea to our patients. Of course, aside from you, Nirmish, none of us are pediatricians, but I think it's important that the audience knows that the recommendations now are to offer hydroxyurea as early as 9 months of age. And I think that triggered for us or myself as an adult focused sickle cell specialist, that I need to be offering it more liberally to all of my patients with sickle cell disease. regardless of how they look clinically today, because the progression of disease, although it may look different for each patient, is generally inevitable. And I think hydroxyurea has shown to us that it has the capacity to reduce the development of chronic organ damage, to improve survival. And the earlier we get it into patients and the higher we push the dose to maximally tolerated dose, the better we are at getting some efficacy. So it's not just about VOC reduction, it's beyond that.
Yeah, I agree with Biree,
Yeah.
actually. Having the results of the baby hug trial really changed everybody's perspective. And now I can tell my patients with sickle cell disease and also those with myeloproliferative neoplasms whom I'm placing on hydroxyurea, look, we give this to babies with sickle cell disease. This is how safe the drug is. Because unfortunately the drug still carries some stigma associated with it as a chemo drug. But yeah, it's unfortunately your question has a simple answer, that hydroxyurea remains the cornerstone of therapy. I shall mention transfusions remain another important treatment option for our patients. But hydroxyurea is at another level as compared to crizanlizumab or glutamine, is much more important in the armamentarium that we have for our patients. It is going to remain the backbone and of drug, a combination therapy, which I think is the way to go for this disease. Hydroxyurea will remain as a very important asset because it's quite clear that it works across multiple populations across all over the world. We've seen it in sub-Saharan Africa, in Brazil, in Europe. I mean, the REACH study, the NORM study, all these studies have shown consistently the benefits of hydroxyurea, including benefits we didn't even expect, like a reduction in malaria episodes in sub-Saharan Africa. So the drug is safe, the drug is effective, and it's here to stay. Crizanlizumab enthusiasm waned in large part in the United States after the STAND phase 3 clinical trial. Approval was revoked by the EMA in Europe. And so, we don't use it that much, but I think the consensus is among patient groups and providers alike is that some people do benefit from it. For instance, those with priapism and other subpopulations. So we may add crizanlizumab in some select cases, like, for instance, in those with hemoglobin SC disease. That's a group that may benefit. L-glutamine, I don't know about you all, but after the initial clinical trial, I haven't seen much in the way of evidence out there for this drug. And so I think it's still used to some extent, but again, everybody's become very lukewarm to it. And in the absence of supporting data and more evidence.
So I think the next kind of thought is then, let's say I have a patient who is on hydroxyurea, and it's absolutely, of course, true that we have patients on the pediatric side many times do well because they're a pediatric patient and they haven't had the lifelong disease to burden. But at some point, inevitably, there are issues that start to occur. And so if we have a patient now who's on hydroxyurea, and we're now starting to have more pain crises or having evidence of some nephropathy or some sort of evidence that I need to do more, what can we do? And so here, of course, we was just brought up, we don't really have much options at this moment. But I did want to just maybe bring in kind of a little bit of conversation about what is your qualifications for discussing and maybe even moving towards gene therapy. I think it's probably a good opportunity to just at least throw it out there and see, since we don't really have much beyond hydroxyurea. So what are your thoughts to when to have that conversation? How do you have that conversation? What's the right patient that you think currently might be a candidate for that?
So this is really an important question, Nirmish. And I think if you ask 10 hematologists, you get 10 different answers. But that said, it's because it's early days. We've only had gene therapies approved in the United States for, I think, just under 2 years. So there's not a lot of real world experience with instituting either of the approved platforms quite yet around the United States or around the world for that matter. But you know, if you look at guidelines on curative transplant and how to select patients, and take allo hematopoietic stem cell transplant as an example, the ASH guidelines really recommend that if someone is having frequent vaso-occlusive crises, recurrent acute chest syndrome, that those patients should be considered for allotransplant. And I think you can extrapolate those guidelines and use them for gene therapy. And I think if a patient does not have a full sibling match, who is available for an allotransplant, then consideration for gene therapy should be the next step. And I think that what we're going to find as we move forward and we look back and we do research, we're going to see that we've been waiting too long to refer adult patients, because they do develop, in some instances, cumulative organ damage, severe iron overload, red cell alloantibodies that preclude their ability to undergo, whether it's allotransplant or gene therapy. So the earlier that we can identify patients, select patients for these curative or curative intent therapies, the better, or we'll miss the opportunity. But for me, just to hit it home, anybody who is not responsive to maximal doses of hydroxyurea, who I am convinced is actually taking the hydroxyurea, I'm beginning to send them for gene therapy consultations earlier.
Yeah, I mean, you know, Biree said you asked 10 providers, you get 10 different answers. My answer is not going to be that different, but I shall say again, one other option before jumping to gene therapy or transplant is, again, chronic transfusion regimen. I do have people who do not develop, you know, they do not have a genetic predisposition to developing red blood cell alloimmunization, who have successfully been able to undergo chronic transfusion for a long time. They do very well. I may actually want to quiet down their disease that way first. One, you know, and I usually discuss gene therapy alongside stem cell transplantation, including haploidentical transplant. Some of our colleagues out there are strong proponent of haplotransplant over gene therapy still. And so I try to provide the patients with equipoise about these treatment approaches, because, you know, again, there's still a lot we don't know. I suspect that at some point the decision may come down to the health of the stem cell compartment. I'm very worried that in those patients with particularly SS disease who have had multiple pain episodes, bone necrosis, bone infarct, the stem cell compartment may be compromised, and the efficiency of an autologous reinfusion of their stem cells, essentially that is required for gene therapy, may not be optimal. And these patients may benefit from an allo transplant. Whereas I have a young man right now who's been on exchange transfusion all his life because of a history of stroke. I expect his stem cells to be much healthier, and also his the microenvironment of the marrow to be much healthier for an autologous infusion required for gene therapy. But I think it's going to become, it has to become much more precision medicine oriented, the decision, you know, and right now we still don't have the tools to make that decision, of course.
Yeah, and I think that there's of course a whole nother, we could talk for, I think, for a long time about gene therapy and how it's evolving and where it's going. But again, being respectful of time and of each and every one of you, what I wanted to move to is maybe just what's really close in development. And so, you know, we're seeing a wave, and we've seen waves of pharmacologic therapies under investigation. And that includes PKR activators, polymerization inhibitors, long-acting P-selectin inhibitors, complement inhibitor. I mean, the list kind of goes on, but they're not FDA approved. They're in studies at varying levels, you know, from phase 1, 2 to 2, 3, et cetera. So maybe just if you could just talk to some of the mechanisms that seem more exciting to you, as well as maybe talking a little bit without, again, maybe getting too far down the rabbit hole of inclusion exclusion criteria. Are we being too narrow? Are we being mindful of the fact of we're just trying to get the clinical study done to get approval. So I mean, there's a lot to talk about here, but just I think to talk about the mechanisms of interest that seem interesting to you and coming, as well as do we have the right inclusion exclusion criteria for these studies?
I don't know who wants to start. I guess I can get started.
You can start, Enrico. Yeah, let's
I'm,
go.
I'm happy that we are now much more prone to including individuals with subtypes of sickle cell disease that are not homozygous hemoglobin SS sickle cell anemia. So right now, it is becoming a mantra that we need to include individuals with SC disease and S beta thalassemia. These are S beta plus also, because they're, it would be a great disservice to these groups of individuals. I'm also happy that the latest clinical trials are conducted upfront in their global studies, multi-center studies that include Sub-Saharan Africa, that include Brazil, and are starting to include India, because these are the hot areas for sickle cell disease. And so it's critical that we do this, because, again, we cannot retrofit a drug that was only tested in the US and Europe to Sub-Saharan Africa. We know that there are pitfalls with doing that, as the voxelotor and crizanlizumab experience teaches us. So I think that's very important. I find the pyruvate kinase activators to be very exciting. They are, quite in quite advanced development, and I think that there will be a silver bullet. I don't think so. I still think we'll need probably combination treatment, but I think that we have at least 3 drugs under pretty advanced development: mitapivat, etavopivat, and tebapivat, and they seem to be well tolerated and definitely induce hemoglobin quite well. So we'll need to see whether that translates into other clinical outcomes, but those are quite promising in my opinion.
I would agree with that. I think for me, any drug in the pipeline that is a fetal hemoglobin inducer, I think is still exciting for me, particularly if we're able to identify oral fetal hemoglobin inducers that are either more tolerable or easier to administer, or more consistently achieve higher fetal hemoglobin levels in patients. I think that for me is still exciting. And that gets back to what you were saying earlier, that it doesn't matter where in the world or what genotype or what age. Hydroxyurea, one of its mechanisms is fetal hemoglobin induction. It works. So if we're able to find a fetal hemoglobin inducer that can reliably get everyone to 30 to 40% fetal hemoglobin, that would definitely excite me as well.
Yeah, particularly if it's a pancellular induction. I mean, that's really going to be the key, right? Because that's what gene editing does, right? It's a pancellular induction of fetal hemoglobin. Hydroxyurea, as we know, unfortunately, leaves some reticulocytes that remain poor of fetal hemoglobin, and so those remain the thorn in the side, right? Because even if you have a high total fetal hemoglobin level, if you have some residual hemoglobin F low cells, that's unfortunately a Trojan horse for vaso-occlusive crisis.
Yeah. And that's exactly what I was going to bring up. But the pancellular aspect of this is actually pretty important, just trying to get maximal effect of the fetal hemoglobin. Now, the next part of the discussion I wanted to guide towards is actually something that Donnell's brought up as well, is just that as we're having more patients that are older with sickle cell disease, and we have therapies coming, we now have to start having conversations about not only how do we make sure that older patients are represented in the clinical trials, so that's the first part of the question, but how do we also strategically be mindful of the fact that we're going to have patients on more than one medication. I've already started to have that introduction to patients, and Enrico, you brought this up. Hydroxyurea is the cornerstone right now for therapy, but we're going to likely have to add to that, and of course the studies are doing that with patients on hydroxyurea. So Donnell, tell me a little bit about, how do you think we can be hopefully successful in getting patients to take more than one medication now, for sickle cell disease, and already once a day, but maybe twice a day. What are your thoughts for that?
Yeah, and I think it's going to be important to educate patients about these medications, the importance of taking them. I will be honest, one of my biggest fears is kidney failure. I don't want to be on dialysis. I don't want to live a life on dialysis. So I know I want to take those ARBs to make sure that I'm protecting my kidneys. But we also have to, look at individual patients. Their decisions may be different, and there might be several different things that drive those decisions, particularly as we look globally. Individuals have different barriers to getting therapies, and we can look outside of the sickle cell community. We know that individuals in African American communities are at higher risk of cardiovascular disease, of having diabetes, of having hypertension, and we see that there are deficits in those diseases as well, so that we're not always able to get individuals to take the medications that they need to take. So sickle cell disease isn't alone in this. It's with other diseases. And then we can tease out that, well, some of this is due to the social determinants of health. Some of this is due to, hey, does an individual have access to insurance? Do they have access to resources to pay for their medications? And then also, as we mentioned earlier, neurocognitively, are they astute enough to say, hey, I need to be on my medicine every day. I need to take my medicine. I will go back to what Biree and Enrico said earlier, that, we saw that with the baby hugs study, there was a transition in the way individuals think. I'm hoping that that transition also comes with potentially curative therapies, so that we are identifying individuals at younger ages to undergo either allo transplant or auto transplant, either with a donor or with gene therapy. And my hope is that as we do that, we have fewer and fewer patients that then need to be on hydroxyurea because they've had the gene therapy. They have fewer and fewer patients that have that end organ damage that they have to worry about. And that may help in some cases. Fewer individuals that if you had the transplant when you're, very young, you may not have those silent infarcts occur or be at risk of overt strokes. So my hope is that as we look at advancing medicine, we are able to communicate to patients, we are able to identify those individuals at risk, and we are able to get them those resources, whether it be cell and gene therapy, whether it be a donor transplant, to really help them to avoid many of the end organ damages that we have. But I do think that, hey, as an older patient, also include us because we are living longer. We are out there. We do have things that we want to be assessed and evaluated as well. And just if I may say, now hydroxyurea has taken some of the burden off pain. There are still a lot of individuals with sickle cell disease that have acute pain, and we do have to find strategies that address that. But now there is a shift to, well, what are some of those patient-reported outcomes that we need to keep in mind? As individuals move from, hey, now I'm able to do better in school and develop a career. Well, what are some of those situations, or what are some of those parts of my diseases that might inhibit me from having a career, might inhibit me from doing well in a career? And that can include fatigue, that can include other symptoms that we usually don't think about with sickle cell disease, but that can be a huge burden to those individuals living with sickle cell disease. So I'm very excited about pyruvate kinase activators because they may, reduce some of the fatigue that I have, and that can help me to be a more productive person, even beyond, the pain.
I mean, that's a perfect segue to the last part of our discussion, which is really, as I said at the very beginning, trying to involve the patient voice. We want to have shared decision making with the patient to try and make sure we decide what's best and what is meaningful in trying to get you to where you want to be. And so I think, again, to bring up to the panel, so what are non-pain symptoms that we talk about? Fatigue, sleep disturbance, emotional well-being. what are the parts that probably make the biggest impact in your patients as you have these conversations? And probably the most important question I think would be great to hear from each of you is, how do you ensure these symptoms aren't overlooked? How do you routinely have this conversation in clinic when we know, of course, we keep gravitating back to pain, which of course is very important, but there's all these other aspects that we need to address as well. So I'd love to hear each of your thoughts on that too.
Well, I have to say that in my 20 minutes of allotted follow-up time for my patients, pain dominates the conversation. It's number one, number two, and number three concern for my patients. So it's very difficult to get to the rest. Insomnia, fatigue, all the psychosocial stressors that are there. That's why I always try to involve my social worker and say, hey, I'm going to go in, talk to the patient. Please go in and ask those questions. I won't have the time to probably discuss with my patient. So a plug for how important it is to have a social worker. We have a Commonwealth of Pennsylvania grant that funds this position. It's absolutely critical to address all these issues. Yeah, it is important to address them, absolutely. But again, pain is such an overwhelming concern, particularly in the United States, and we've got to be mindful that it is when you talk to individuals with warriors living with sickle cell disease in sub-Saharan Africa, South America, pain is not such an overwhelming concern for them. Acute pain, yes. Chronic pain, not as much. I think a lot of it is iatrogenic, something we have created in the United States because of our prescribing habits. But unfortunately, it's there, and it's going to be there and it will be there, and it will stay there, because a lot of the treatments that are being approved will only address vaso-occlusive crisis rate. They won't really address the burden of chronic pain. So I'm sorry, I'm shifting back to pain. I know we want to talk about other concerns, but I think that a lot of it is so linked to pain, fatigue and insomnia and psychological distress. They all go back to pain and stigma and discrimination. Pain is the common denominator for a lot of this.
Yeah, I think my interactions end up being very similar to Enrico's, and I think because also we are prescribers of opioids for a significant proportion of our patients, particularly adult patients, I think there's a requirement that we take a deep dive into the pain experience, the pain medication utilization. So we're really capturing use of prescribed opioids and making sure that we are prescribing in a way that is compliant with regulation. So that's another thing that I think really drives our discussion towards pain, is because it's tied to our ability to give prescriptions for opioids, and we have to document those things. What I've tried to do more recently to try to not have the encounters focus so much on pain is I ask my patients, okay, before we get started, I want to know what do you want to accomplish today? What do you want to talk about? And I jot that down to make sure that I circle back to that. And it's not always about pain, which I think is what we're getting at right here. Like, what is it that the patient, the lived experience is driving? And what I'm beginning to hear is it's about function. It's about sleep, fatigue. It's about keeping up with everybody else, no matter, we think of that as like young adults and adolescents caring about keeping up with their peers. But to Donnell's point, even people who are older are trying to keep up with, say, grandchildren or keep up with their peers. And some of my patients in their 40s and 50s are telling me that they feel that they're aging faster than their siblings who don't have sickle cell disease, or their friends without sickle cell disease. So they want to address those issues. And of course, there are the psychosocial issues that some of our patients experience, not all, that sometimes come to the forefront and impact their ability to, quote unquote, be compliant with therapy. And Donnell, you've mentioned those things like access to medications, financial constraints, housing, interpersonal conflicts. There are a lot of things that our patients go through, or some of our patients go through, that really do get in the way. And those, if you want to call those a patient-reported outcome, I don't see any reason that we can't, because that influences their clinical care and their clinical course.
Yeah, and if I may just say, I don't have statistics that definitively answer what's happening, But I think if you look at pain and how many are reporting it, we may actually see that it's not as many people as perceived that are talking about pain. It's just our perception is that a lot of individuals with sickle cell disease are talking about pain. But I think Paula Tanabe's study, which demonstrated that there were about, really, when you look at individuals that have utilization practices, it was about 30% that utilize the ED more than, say, 5 times a year. And so I think we do have to step back, particularly with individuals that, hey, they've been managed on hydroxyurea for years. They're trying to live a life outside of the hospital, that our perception isn't driven by, well, you know, a lot of the individuals that are coming to the hospital or that we're encountering are dealing with pain. And we do have to make sure that we're addressing their concerns. But I would like to, you know, see the data. You know, how many individuals is it really about pain? And then also, I'm going to say something that I hope it's not too controversial, but it goes back to what Enrico said earlier. You know, we've created a problem in the U.S., and that problem isn't limited to just individuals with sickle cell disease. I think we can see today that our males between, I'm going to say, 16 and 25 are having a hard time generally in the U.S. That there's something going on that's driving in males between a certain age to have difficulty. And so our individuals that are dealing with sickle cell disease having that experience on top of it. And I bring that up to say that I think we have to think outside of just sickle cell and make sure that we're looking at individuals getting psychiatric support, individuals getting other support to really help address their disease. It was mentioned earlier, well, you know, hey, well, what about these other subspecialists? I think neuropsych and I think psychology and psychiatry is a very important one that we may overlook and say, are we helping individuals to adjust? We can see in the data that there's something happening in the sickle cell community at that transition period. Is it that the patients are having more difficulty, or is it that the healthcare system has not evolved to really capture what's going on in their lives? And so I don't want to minimize pain. I've been fortunate that hydroxyurea has really helped me, and I haven't had a sickle cell pain crisis in a very, very long time. So I know pain is important, but I think we also have to help patients to realize that, hey, getting on a medication like hydroxyurea can help you live a longer life, but also a healthier life and have a career, and then help those individuals transition so that we are addressing those other issues, including psychological, that can help them be the most effective they can.
Yeah, those are great points, Donnell. I think, you know, that I find that the subspecialists with the best set of skills and knowledge to manage people with sickle cell disease, you know, and I'm saying sickle cell disease is such a chronic whole, you know, global disease affecting the global functioning, are palliative care doctors. And, you know, because they don't just focus on pain, they focus on all symptoms, and they understand the interconnectedness of all the symptoms. And that's another plug I like to you know, towards palliative care, because that's really a professional figure that I hope one day will be able to support a lot of us.
Yeah, I think that again, it's a perfect opportunity to kind of bring up that the emphasis comes back to the patient experiences and lived experiences with sickle cell disease, and it's not just pain. I mean, the SWAY data said fatigue is there. I mean, there's so many aspects that we're not addressing. And so the clinical trials, and this is probably the last question before I hope to maybe just wrap some of these thoughts up, but the clinical trials are recognizing this, and so they're including patient-reported outcomes, validated measures for physical function and for pain interference. And I guess my final question here is, so of course that's recognized as important, and that's why they're doing it. But how do we now weave that conversation in with patients? Is that how do we have that conversation? Do patients want to hear that it improved pain and their hemoglobin, for example, which is some of the outcomes coming Or do they want to hear that, yes, it also improves physical function? And I think it's a little bit of a loaded question, but how do we have these conversations and make that emphasis as well?
Well, I'll start. I mean, with some of the clinical trials I have open, you know, I'm able to say, well, earlier phase investigations with this agent not only showed, you know, reduction in pain, improvement in hemoglobin, but improvement in fatigue. And that I will tell you is I see my patients, you know, eyes light up and they're, you know, so that segues into a discussion about how impactful fatigue is on daily life and daily function. So if that's what you're asking, Nirmish, I mean, I can use that as a case example. So I think our patients are very interested in identifying new treatments and participating in clinical trials that have a focus on patient-reported outcomes, whether that's fatigue, sleep, depressive mood symptoms, anxiety symptoms. Yes.
And not to put you on the spot. Hey, go ahead, Enrico.
And besides the patient-reported outcome, I think another good measure to include in clinical trials and also in practice is the 6-minute walk test, because it does provide a more global assessment of functional status of the patient. And I know it's not a patient-reported outcome, but it is something that is increasingly being recognized as an important metric.
Yeah, and I'll just add that I'm a huge supporter of using patient-reported outcomes in clinical trials. You know, as I said, I've been fortunate enough to have a situation where hydroxyurea worked for me, so pain became less of an issue. But those sequelae or those consequences from end organ damage are a major concern of mine, and so it is the neurocognitive ability, it is the fatigue that Biree mentioned. It is my ability to do what I need to do as a man, like, you know, to live a life that I feel is productive, to be a contributing member of society. I will say that I would like to take it a little further than patient-reported outcomes, because if we do the studies at just snapshots in time, I think we get different answers. We have to have a way to look at individuals across time. So I like to think of it more in my mind as like home reported outcomes. What are some of those things that are happening in the home setting in a person's life? You know, it's not just a snapshot. Hey, I came in to the clinic. I just happened to come in when I was having a bad day or a bad week. But what's happening on my good days, on my bad days, and everything in between? What's really happening to me? And I think if we can help patients to start doing that, maybe they can see that, oh, well, actually pain isn't the biggest issue. It is fatigue. Maybe in some cases, patients aren't aware of what those biggest issues are because they're only looking at themselves, snapshots in time, and not looking at, well, what does life look like over a longer period of time? So I think hopefully we can develop strategies that help us capture that patient-reported outcomes, which can lead to capturing home-reported outcomes, you know, societal reported outcomes. What are those burdens that exist that are truly on me, that are inhibiting me or limiting me from living the life I want to live?
Yeah, and I think that the use of e-diaries and all these aspects get to resonate really well with patients where they're trying to provide their experience at home. And so your terminology of a HRO, a home reported outcome, will probably be something that'll be picked up from this point forward. That's great to know. So, as we draw to a close here, this has been an amazing conversation. I mean, I think it's clear that the future of sickle cell care is already here. And, its distribution is uneven. And so we've heard a powerful consensus on several key shifts. So, first, the move from reactive pain crisis management to being kind of proactive, risk stratified organ surveillance is really the paramount issue. Second, we're at an inflection point in therapy. We have excitement about this new wave of treatments that are coming. For instance, we have oral options that may address more than one disease pathway. And finally, we've affirmed the mandate here to embed the patient's lived experience and really even just how they're doing at home, not only in clinic and in one point in time, into every care plan throughout the routine use of quantitative quality of life type measures. So to my colleagues and my panelists here, thank you so much. I appreciate your time. And I hope you had a great conversation with me as well. Thank you. Thank you so much.
Nirmish. Thank you all.
Thank you.
Thank you.
Thank you.
What an incredible discussion. We are so grateful to all of you for that really in-depth session. Thank you so much, Dr. Shah, for chairing so expertly, Dr. Novelli, Dr. Andemariam, and Dr. Ivy for contributing all of your thoughts to that session. I'm going to bring up on screen for you just now a QR code, and I will also place a link into the chat box on your screens, and it will allow you to claim a CME certificate for attending today's session. It will ask you for some feedback. We really appreciate it. We want to make these sessions as helpful as possible for you, our colleagues, and I hope that you find today's session and discussion really useful for your practice. We'd love that feedback. It will allow you to claim the CME certificate after you give us some feedback, and it will automatically be added to your medal account and you'll be sent an email. Really simple. Thank you so much for joining us. It has been a pleasure to host you today, and I hope that we will see you on another session sometime soon. Just as a massive thank you once again to our panel.